We have created a medical task force with the United Way, with Acadian Ambulance, with Love Our Community, with the Schumacher Foundation and our nonprofit club to address issues with our COVID crisis and disparities in healthcare crisis.
Coronavirus infection is highly contagious, mostly transmitted by droplet infection. If you experience any flu-like symptoms, including muscle pains, fever, cough, shortness of breath, please stay home, quarantine yourself, and seek medical help.
It is still very important for us to avoid large crowds to decrease the spread of COVID-19. Despite being asymptomatic, if one person's infected, you could bring this home to your friends and family, thus propagating this pandemic in the community.
I would have to say that it's very important during our pandemic to be sure that all of us use our mask when we go outside, and we keep distance of about 6 feet or 2 arms together from each other.
There are several locations in the community that's providing free COVID testings. You only have to provide an ID, insurance, and even if you don't have insurance available, they still will do the testing for you at no cost.
Communities of color have been hit the hardest by the COVID-19 pandemic. Well, I've got some news for you. We can take care of you regardless of your ability to pay. We have first-class care that we can take care of you.
COVID-19 is not a hoax. We can stop it in its tracks. You must never go about your daily activities without wearing a mask. The mask, it will prevent the transmission and spread of this deadly virus.
I'm here to talk to you about protecting vulnerable members of the population. Think about helping them attend a faith-based service online. Other things that you can do are running errands for them, like grocery shopping or medicine pickup.
Scrubbing your hands, washing your hands needs to be done a minimum of 10, preferably 20 seconds. You can use soap, water, or hand sanitizers. Minimal 10, but preferably 20 seconds.
Now is not the time to put it in fate's hands. Be proactive. Let's everyone get tested.
Welcome, Acadiana. I'm Dr. David Ollie. Welcome to this month's Dr. Ollie and Dr. Pat Lola Community Medical Live Call-In Show. You can see by our announcement that we're going to address another pandemic or epidemic tonight, and that's going to be peripheral vascular disease. Now, please take note of the PSA and the announcements about COVID. From that standpoint, I want to make sure that you understand that it is very important that we do follow these rules. The mask is very important. As a cardiac surgeon, I spent 30 years wearing a mask almost 6 days a week for 12 hours a day. And I did that to prevent infection and to save the life of the patient. We do it today for the same reason: prevent infection, but also save lives. And that includes yourself, your family, and others. So please wear the mask, and please understand that we still have a pandemic. So welcome to our show tonight. And with that said, I would like to introduce Dr. Pat Lola and Dr. Roshan, but we are going to go ahead and take our mask off at this time because we are socially distanced, as you can see, and we've all been recently tested as healthcare providers. And so we're going to move on today and talk about peripheral vascular disease. Dr. Pat Lola, to my right, my co-host, my partner, I would like for you to say hello to the audience, but also make a little comment about, as a cardiologist, what you have experienced in your 25 years, which I've seen, treating peripheral vascular disease. And by the way, I believe you're one of the most talented and experienced peripheral vascular interventionalists in this world today. Dr. Pat Lola, tell us about cardiovascular disease and peripheral disease.
Thank you, partner, and Dr. Ali, I'm humbled. Peripheral artery disease, even today, it's a big problem. Even though there's much awareness in the community and across the world about this major disease, still there is a significant undertreatment of this problem. And the biggest problem is that there are certain conditions which can promote and make this condition even more serious, including diabetes, which has become a major pandemic across the world, hypertension, high cholesterol, smoking. All of these things have really become a big problem in making this disease like a pandemic across the world. Of course, now we have major therapeutic strategies, balloons, stents, atherectomies, which we'll talk over in the next 1 hour. It has significantly improved the outcomes of this disease process, but still there is a significant lack of awareness of this disease, and that's why we are here to educate our community as the physicians, your physicians in the community, to make you aware of this dreadful disease, which is potentially treatable, preventable, and also prevent amputations.
Excellent. Dr. Pat Lola, thank you very much. And now, on the same tune, I'd like to introduce our co-host and partner also, Dr. Brent Rochon, who is from this area. This is his community. He's born and raised here. As a younger cardiologist, he also has seen the ravages of peripheral vascular disease in his own patient population. So, Brent, welcome. Say hello to the community and give us something from your heart on peripheral vascular disease.
Good evening, Acadiana. Thank you, Dr. Ali. Thank you, Dr. Pat Lola. Happy to be here and happy to be part of the group. I was the first hospitalist in Lafayette, Louisiana, and many of you may know that there are many hospitalists now in the community where I first started having multiple interactions with a large variety of patients. Being born and raised here, 20 years, more than 20 years as a physician and 10 years now as an interventional cardiologist, I've seen cardiovascular disease and specifically peripheral vascular disease ravage friends, families, and multitude of patients in my community. I'm happy for us that we have the access to a venue like this where we can directly engage with the public, which aside from a patient visit, it gives us a chance to get out to talk to you guys. We do a limb salvage club where we have a community meeting, but some people can't make it, and this way we come to you. So you can look at this as a house call. I'm happy that we have a venue like this. Thanks for setting it up. With that being said, I also would like to take this to mention about another crisis that we're going to be unfortunately dealing with, and we could attribute this to another pandemic, but Hurricane Delta. I want to take this as an opportunity for the patients. Please make sure that you have enough of your prescriptions filled. Make sure that you have clean water. Those of you in low-lying areas, please heed the warnings and evacuate it if needed. One other thing, we're all family. This is all a community. Check on your elderly neighbors. Check on your infirmed neighbors. Check on your friends and family. We're all in this together, and good luck through this hurricane in Acadiana. Excellent.
Thank you, Dr. Rochon. Guys, before we get into any little bit of lecturing and live call-in shows, I want to take a second. I'm going to ask the cameraman to take a little close-up here. I want to introduce a book. We talked about this last time. This book is going to be provided very soon, and I want to tell you real quickly. 14 years ago, my partner, Dr. Pat Lola, came to me and asked me if we would write a book. I hedged on that and told him I flunked spelling. I wasn't a very good speller, nor English. I would help him, but he had to do the writing. A decade went by. Passion, behind the scenes, he was writing this book. He brought this to me 6 months ago, almost completed. I was honored to be a part of it. He has done most of the work. He asked my advice, and I told him to put in 2 more chapters, COVID and disparities. He has done that. So we now have a book. I'm going to let Dr. Pat Lola describe that. This book has been written for our community, and it will be provided at complimentary to our community, to our patients, and to our club members. And please go to our CLI Club webpage. You will see that. You will be able to have access to this book. Dr. Pat Lola, please tell us in your words about this book.
Well, I would say this book has been written not just by me, but under the advice of Dr. Ali. It's a labor of love. It took a lot of time and effort to do this. The whole idea of this book is for the community. I want the community members to read this book. It's simply written with very simple language, not too much of medical terminology, so anybody could read it and understand it. The purpose of this book is to understand your disease process and participate yourself. Be aware when you see a physician in the care of your disease. Ask them questions, confront them, and they will. You being an informed patient, you will have a better advantage, and you'll have a better control of your destiny as far as your health disease is concerned.
So, to the audience, this is a community call-in show. We have a community club. We have a community book. And this is what this is all about. And so with that said, let's now embark upon some discussions about peripheral vascular disease. And if I can have the first slide, and we're going to give a little bit of information on peripheral vascular disease, and then we're going to take in some live call-ins, okay? Now, peripheral vascular disease is a very large topic, and from the standpoint of vascular, this would include arteries and veins, but we're going to do more discussions and statistics on the arteries than the veins today. We will likely have a vein program in the future, but we expect some calls on veins since it's a part of the vascular disease. But what are the symptoms? Pain. Okay, so the word pain can be taken many different ways, and there's lots of different kinds of pain. You can have pain at rest, you can have pain walking, but one of the symptoms is that from peripheral vascular arterial disease and venous disease is pain. Now, also numbness and weakness. These are also symptoms that have to do with nerves, back, diabetes, but also vascular disease. Skin discoloration or coolness of the skin. If you have a colder foot, one than the other, this is very significant. Skin discoloration oftentimes is a symptom that may be thought to be a dermatology problem, when really it can be an underlying vascular problem. Swelling, or what we call edema. This can be due to many things. Medications, injuries, but also to vascular disease. And any type of wounds or sores that you want to have would be a significant thing or a symptom of peripheral vascular disease. Now you can see right above my head, I also have no symptoms, because in the world of peripheral vascular disease, this includes arteries of the carotid arteries, the renal arteries, and they don't have symptoms. So if you take anything from this slide, understand that any of these symptoms, including no symptoms, can be confused with back, with diabetes, with dermatology problems. And so the answer here is that really symptoms are important, but the best way to have this diagnosed is for you as a patient to contact your physician, contact your doctor, because we have tests that will help us, and we'll talk about those, differentiate what causes these symptoms. Many times we have back symptoms and we have leg symptoms, especially if you're older, especially if you're diabetic. So with that said, these symptoms are important, but they're just a very small part of this. So let's talk about diabetes, because you can't talk about peripheral artery disease without that. You can see some statistics there. 200 million patients worldwide have diabetes. 92,000 patients lost their limb in 2012, and these were diabetic patients. Diabetes is going to increase by 2030. Next slide, please. Over 300 million U.S. citizens with diabetes. Somebody dies from diabetes every 17 seconds. This next slide is a little bit of an error. One would have an amputation every 30 seconds. Difference in 7 seconds and 30 seconds, not that much. Amazing statistic that somebody with diabetes ends up with an amputation every 30 seconds. 1 out of every 3 diabetics will have peripheral arterial disease. They are first cousins. Next slide. Ongoing with diabetes. Higher incidence in African Americans, Hispanics, Latinos than the Caucasian population. That is exactly who we have in this area and actually worldwide. U.S. costs, diabetes, $182 billion. $182 billion. This is a tremendous U.S. cost. Again, the risk of developing PAD, much higher. Next slide. Diabetic foot ulcers. Diabetes lends itself to this, and you can see that 25% of the patients with diabetics are going to have an ulcer in their lifetime. Once you have diabetes, especially at a younger age, there is no cure for diabetes, and so we're going to be looking at some type of ulcer there. 1 out of every 4, and that's 30 million, will have one in their lifetime. If you look statistically, the number one cause of hospitalization for a diabetic patient is not high blood sugar. It's not those kinds of things in the past. It is actually a diabetic foot ulcer that's got infected that requires treatment. 70% of all amputations in the U.S. are in diabetic patients. 85% of every amputation is preceded by a diabetic foot ulcer. A little typo there. The OPM should be DPM. That means that means the podiatrist, the doctor of podiatric medicine. The reason I'm saying that is your podiatrist or your foot doctor is very important here, because we do believe that proper foot care, proper shoes, etc., most of these diabetic foot ulcers are actually preventable. Now, here's your statistic. Worldwide, an amputation in a diabetic patient every 30 seconds. So this is diabetes. Let's go on now to peripheral artery disease. How are they connected? 12 to 14% of the world's population has PAD. 22 million Americans have PAD. Huge population. You can see one of the three of the diabetics at an older age group is going to have diabetes. And 20 to 50% of the patients with PAD, again, have no visible symptoms. That means you can look at them, they just don't have anything that gives it away. Yes, wounds and ulcers and things like that, but many do not. Next slide. Medically speaking, this is the way that we see this, okay? This Rutherford classification is a little bit fancy here, but it simply means the severity of the PAD. If we grade it 4, that means they have pain and they have very little blood flow to the foot. A classification 5 means they have a sore and a wound that's not healing. And 6 means they have gangrene. This first note is from a study that was done in the 50s, in 1950s, before we had these treatments. And what this says is that once they get to that level without treatment, that means the natural history is they're going to lose their limb, because there's no treatment, there's no cure, an infection, they will end up having an amputation. There are 220 to 240 amputations in the U.S. and Europe every year. A lot of statistics here. I don't want to overburden, but I want to make the point how bad this is. Perioperative mortality, that means once they have an amputation, they do not live through this. This is general anesthesia, there is blood loss. We want to do everything to avoid an amputations. There's more than 20,000 amputations a month. Next slide, please. Critical limb ischemia, or CLI, is the status of this advanced Rutherford classification. Once they get to that point, again, they're advanced. You can see within 1 year of the diagnosis of this critical limb ischemia, that means they have very little blood flow to their foot. 30 to 40% are going to have an amputation. 25 to 30% of these people are going to pass away, or they're going to die of this or heart disease or something. And you can see statistically there, it's much higher in the elderly patient population. And we have many more older patients today than we did just 10 years ago. Next slide, please. 8 to 15% of these amputations, once they have them, will end up dying before they get out of the hospital. That's because they're infected, they're septic, they have heart disease. It's a tremendous shock to the patient when they have to have an amputation. It's not a benign or simple thing. Once they have an amputation, if they live through this, and most of them do, but it's an impact. 25% of these people will have to have assisted living. 1/3 of these amputations will lose their other leg within 18 months. This is a hard statistic, and it's a staggering statistic, because it's the same thing affecting the other side. Only 50% of these patients who have an amputation will be alive at 4 years. Next slide, please. 50% of these will only 50% will even be mobile. We think that they have an amputation and they put a prosthesis and they ride a motorcycle. That's not true. Now, younger patients for trauma, yes, but this is a tremendous effect on a patient and their family once they have an amputation. Here you can see again the death tolls. Here you can see that 1 out of every 4 of these patients are going to have this if they're diabetic. $23 billion a year in peripheral artery disease, a little less than diabetes, but still tremendous. And that is in the face of reports that show 85, 90, and even 93% of these patients can be saved if we get to them early. Next slide, please. What happens after they have this amputation? If they go to a nursing home, $100,000 a year to take care of these patients. If they go home, many things that changes that we don't even know about. New toilet seats, ramps in the home. In other words, it is a tremendous effect on the family, both in the patient and the family too. If we could just reduce these amputations by 25%, we're saving billions of dollars a year. Next slide, please. Again, this is a significant problem affecting both legs. We see this all the time. Within 18 months after we've saved that leg, let's say with a stent, that same leg may have progression, or there may be another infection occur, and we have to continue to treat that same leg. We don't have any cures. This is a hard, difficult disease to deal with. The other leg is going to be affected 1/3 of the time too. So once these patients develop the first problem, then the history is more of the same. And so in this area, prevention and better podiatry care, diabetes care is very important. Next slide, please. This will be the last of the slides before we get into it and start taking some questions. This is a recent published study that came from 20,000 Medicare patients. They looked at these patients. And again, we have 20,000 patients, and they had an amputation. And they looked at these, and 54% of these people did not even have their blood vessels tested. In other words, they went straight and had an amputation without the doctors seeking specialists who have the new treatments, who have the balloons, who have the stents, who have the ability to save 85 to 90% of them, and even in an outpatient setting today. So to the audience, I've given a lot of statistics, they're pretty hard statistics. They haven't greatly improved, but we need to improve our education, and hopefully this will get to this. So with that said, I believe we have a caller on the line, and I think we have several callers already. So guys, if we can have our first call, we're going to take our live call-ins and field them from there. Peripheral vascular disease.
How does the laser remove the blockage from inside the artery?
All right, we have a quick question. He's talking about the laser. That's a good question. This is one of the things that we use as maybe one of our primary tools. Dr. Patlola, I'm going to ask you to field this question. I think we have a couple of videos on this. It's something that we have a lot of experience in. So give us your little information on laser.
Sure. So laser simply means a light amplification of stimulated emission of radiation. It's a very complex physics mechanism. It's a simple device wherein we advance it towards the lesion, the blockage, and then this emits intense light, and that kind of pulverizes or evaporates the blockage or the plaque, the cholesterol buildup in the vessel wall. Then this is frequently followed by balloon angioplasty, wherein we blow up a balloon to size up the vessel, and eventually, in certain cases, we also use special balloons called as drug-coated balloons, very occasionally stenting. The whole purpose of these lasers is to prepare the vessel, so this way we could get as much of the cholesterol plaque out of the vessel, and this makes the vessel more amenable to treatment, meaning balloon angioplasty and stenting. There are many laser technologies available. The device, what we're seeing here, this is by Philips Spectranetics, and we have tremendous experience as a group, and we continue to train the physicians across the world, across the country, in this very complex disease process to prevent amputation and get them back to their normal life.
So Dr. Patlola, thank you for that. Now I will also tell the audience that last laser that you saw here was actually developed by Chris Hebert, who works with us, who has helped all of us at this table over the last 30 years. He actually patented that laser, and he invented that type of laser called a turbo booster laser. It's the first laser, matter of fact, the first device that actually is FDA approved to remove blockage inside of a stent. This is called in-stent restenosis. So right here in this community, the patent for this top shelf tool that's used nationwide was developed right in this particular town by by Chris Hebert, really in a lot of the work that we have done with him. We've got another caller. Can we have that on the line, please?
My grandfather has both heart disease and leg disease and cannot walk. Is there a stress test today that can check one's heart even though they can't walk?
Dr. Roshan, I'm going to ask you to address that. So this is a viable question. They can't walk, but how can they get their heart checked? Dr. Roshan.
Thank you. We do have multiple modalities available. Older methods include dobutamine stress tests and with the echocardiogram, where you can speed up the heart, thus stressing it, and do an ultrasound before the stressing modality and after. And you look for areas of the heart muscle that may go from moving normally to abnormally. These are somewhat archaic methods that I don't really employ these days. More specifically, the nuclear stress test is the way to go. You can look at a nuclear stress test as we give a radioactive isotope that goes into the heart muscle, and you take a picture of those walls of the heart muscle. Once you stress the patient, either with exercise or once again with another chemical, you expect to see all of the walls of the heart light up that lit up in the rest phase. If they do not, or even if there's not a light up in the stress phase, no light up in the from the beginning and after means that there's a scar indicating an old heart attack. But if an area of the heart lights up before we stress them and does not light up after, this could be an indication of a blockage that's not allowing enough blood to get to that area of the heart. This would then be probably an indication to initiate appropriate medical therapy and probably an angiogram, where we would perform to diagnose the problem and potentially fix it with stents, and if needed, send the patient to bypass surgery. Thank you for your question.
Okay, so this is a way that somebody who can't walk can still have their heart checked. And this is all as an outpatient in the office and is accurate. So we've got another caller. Can we have that one, please? Next caller.
Good evening. My dad just had a stroke and was told his carotid artery was totally blocked, and there's nothing they could do about it. Why is this so, and is he at risk for another stroke?
Well, guys, let me take this one. This has to do with carotid artery disease, and it's up my alley, so to speak, as a surgeon, because this is one of the areas where we still primarily do surgery. Can I have a slide real quickly on the carotid? Carotid arteries go to the brain. They govern motor activity and stroke. You can see in the image here, the blockage is like rust in a pipe. Okay, this shows a case that is actually a carotid stent. Okay, so this shows us going in and putting a stent to open up the artery to get our blood flowing. Now, carotid stenting is generally done only in very complex cases in elderly patients who cannot have general anesthesia. This is an indication for stenting. This is the last place in the body that we actually do stent. In patients who may have a blockage coming back after surgery, this is an indication for stenting. Let me see the next slide, please. This is the standard way to take care of a carotid blockage, and this is actually the opening of the artery. This is a surgical procedure in which we clean out the artery and we close it back. It does a very, very good job. Next slide, please. This again shows the classic carotid endarterectomy, and this is how we treat this. Now, the question from the caller was the fact that she had had a stroke and the artery was totally blocked. And there isn't anything that can be done in that particular scenario, and that patient now is reliant on the other carotid artery. So when a total occlusion occurs and one has a stroke, they are at risk of having another stroke, and we have to watch the other side very, very closely. There are some patients who can have a total occlusion or blockage on one side and do not have a stroke. We think that's about 1/3 of the time, and that is purely luck or in God's hands. But what it means is they're reliant on the other artery as dominant, and so that just focuses on that artery. So carotid artery disease, a type of peripheral vascular disease, often asymptomatic. They have a blockage without anything. We have good treatments, surgical standard, stenting when necessary. It is the third leading cause of death in this country is stroke. 1/3 of the strokes originate from the carotid artery. So it's a very significant peripheral vascular problem. Next call, please.
Is there any blood vessel tool that can actually remove and excise the blockage out of the artery?
The caller is wondering if we can remove the blockage. Now, certainly we do with surgery, but we do have a tool that actually excises and brings it out of the body. Dr. Pat Lola has a lot of experience with this tool. We also did some leading work with it also. So Dr. Pat Lola, tell us about the way that we excise it, and I think you'll have a video you can call up.
Yeah, I mean, this technology we've been using for quite some time. It's maybe over the last 15 years. This is called as excisional atherectomy. It simply it's like a small catheter which has some surgical blades attached to it at the tip of the catheter, as you see that. These are hosed in a nose cone, and we kind of shave the plaque out, as you can see in the video. The plaque or the cholesterol plaque is shaved up, and that is stored in the nose cone. And after the procedure is done, the entire catheter is removed out, and we have a clean vessel, and following which we proceed with the balloon angioplasty or stenting as needed. Again, the whole idea of atherectomy is to ablate or destroy the cholesterol plaque material which builds up in the arteries. There are several ways to do it. This device is called a Silverhawk device made by Medtronics. It works extremely well in certain situations, and as Dr. Ali mentioned, as a group we have tremendous experience using this device for the last 15 years. Its whole purpose is to excise the plaque and get the plaque out. Unlike lasers, which we use it on a day-to-day basis, they basically pulverize or evaporate the plaque, which gets absorbed into your bloodstream and excreted out.
Thanks, Dr. Palola. This is one of the tools. You know, in our toolbox, we have different tools that have different specific indications. Some tools are for longer blockages, some are for soft ones, some are for removal. This particular tool does a very good job on very difficult but isolated blockages in which we can remove them out. Many of the blockages are much longer, and so they're more difficult and they are more applicable than the other devices. Then there are other blockages that are calcified and hard, and so I want the audience to understand that over the last 20 years we've been able to help, as a matter of fact, and receive different tools which we will choose appropriately for each patient. Let's have another call in, please.
Thank you for taking my call. My dad had a heart...
Hi, my mom had her vein stripped 20 years ago in the operating room and looked like she'd been bitten by a shark. I understand that today this same procedure is offered with no incisions and patients leave the office with only a Band-Aid.
Well, caller, my dear, I was one of those sharks because that is the way we used to treat vein disease. That would be with vein stripping and various surgical procedures in which we would simply use surgery to cut them out, okay? Now, though, the fact is, that was the standard of care. But in the last decade or so, we have multiple ways of treating them in the office. And we treat them with what's called ablation. And they do go home in a short period of time. And I'm going to ask Dr. Patlola because this is one of the things that he took on himself and learned this, and he's a specialist in this. We've got some videos of that. I'm going to let him explain because it is a simple procedure and there's a lot of people that benefit from this, and it's done in the office in 10 minutes. Dr. Palola.
Absolutely, caller. So first of all, we compare veins to weeds. If you pull them, they come back. If you burn them, they don't come back. So this is example. Many ways to treat the veins. So one is the radiofrequency ablation, where we use the microwave energy, and the second is the laser energy. In this video, you're seeing the radiofrequency ablation. Here, we just put an IV line in your thigh around the knee area, and the special catheter is advanced into the vein, and then we inject something called as tumescent anesthesia, which is the anesthesia used by plastic surgeons for the last 30, 40 years. It simply compresses and collapses the vein and keeps it safe from the adjacent arteries and the neurovascular bundles. And this device delivers intense heat into the vein. The purpose of this whole heat is to damage the inner wall of the vein. Once the inner wall of the vein is damaged, the vein is collapsed. And now the question comes, what happens if my vein is collapsed and how will the blood get back to my heart? Immediately, within a matter of few seconds or minutes, small veins form around those collapsed veins, and the blood is tracked back in the proper direction back into the heart. Simple procedure, minimally invasive. People leave the office with a Band-Aid. Indeed, people come to the office during the lunch breaks, get these procedures done, and get back to their work in the next hour or so. There's no downtime. The results are very good. Most of these people have a 99% success rate, and the veins remain closed or clogged for at least 10 to 15 years or even forever. It's a very simple technique, very minimally painful, and people come in during the lunch breaks to get these procedures done.
Dr. Palola, I'm smiling because I can remember spending 4 hours on one of these cases, and the patient did look like they were attacked by a shark. And again, it's just another advancement that I have seen and we've been a part of, and great to be able to offer our patients. Now, I gave a lot of statistics earlier on the arteries. I didn't have a chance, and we will give some statistics on veins. But if you think those statistics on arteries were pretty bad, and they are, the vein statistics can even be worse in a sense that there's more of it. Now, the venous disease does not have the same, let's say, death rate, or let's say the same amputation rate, but there's more of it, and it affects many more people, and it causes a lot of morbidity, mortality, pain, and so it is something that we've learned to treat also in this kind of a vein, is in the veins of the leg, and there's other kinds of veins too. So with that said, let's have another caller, I believe.
Thank you for taking my call. My dad had a heart stent placed but has not been checked for peripheral vascular disease. What are the tests available to check him for peripheral artery and vein disease?
Okay, very common question. Okay, so Dr. Rochon, I'm going to ask you to think about this one because, we've got many tests in the office, and this is something you routinely do and in your patient population. How would you take care of this? Because as a cardiologist, you've dealt with his heart. Now, how you diagnose his legs?
Traditionally, this has been performed with the anchio-brachial index to start potentially, which is whenever you compare the blood flow in the legs with blood pressure cuffs to blood pressure in the arms. That being said, we have better technology these days where we do simple ultrasound. Ultrasound, you use a probe and you put basically a gelatin-like substance on the legs and look for flow either in the arteries, which would feed the extremity, or in the veins, which would return the blood back to the central part of the cardiovascular system. This is a very simple in-office procedure that we perform routinely daily, and it gives much more accurate information to if there's a problem in the peripheral vasculature, and actually helps us to locate exactly where it would be. A much more sensitive and specific test as compared to the traditional old anchio-brachial index, which I initially described. I think ultrasound is the way to go, and if it's indicated after medical therapy, we should then probably proceed with the angiogram where we could get to fix it.
Yes, the world of ultrasound naturally has significantly changed too. Nowadays you can see ultrasounds looking into buildings and looking into the ground, and you can see them finding chambers. We're all sort of familiar with ultrasounds in pregnancy and that sort of thing. Well, our vascular ultrasounds are as good, if not better. So we can actually from the outside look inside, tell about a blockage, what's the blood flow, just as he had described, and then that can be done in the office in a few minutes and is very, very accurate. And as a reason, if you have any of those symptoms, which I started with, or none of the symptoms. If you are concerned that there is peripheral vascular disease, you have diabetes, you have a history in the family, this is not something that should have guesswork anymore. Talk to your physician, refer yourself, get to a specialist. These tests are simple, they're in our office, they're outpatients, they're accurate, and we don't want to see amputations, we don't want to wait until symptoms. Earlier the better. Let's have another caller, please.
Hi, I've heard there's a new Roto-Rooter for blood vessels. How does it work and what are its advantages?
All righty, so we've talked about a laser, we've talked about removing blockages with surgery, we've talked about lasers and excisions. Now we got roto-rooters. And yep, we've had roto-rooters too. I'm going to ask Dr. Rochon also to explain this because this has a specific use too, and he'll explain that to you. So Dr. Rochon, talk to us about that.
Yes, very interesting. I think they probably are referring to what used to be Rotablader, which they have a Rotapro, but now we're using more the CSI, Diamondback Rotational Arthrectomy, and we do have a video of that. This has a 1.25 millimeter burr on it that's on a wire and it spins in an eccentric pattern. Plaque builds up, calcium builds up, thus making it hard for us to pass stents. With this new technology, we press a wire across it, and with this diamond-coated small burr, it can spin in an eccentric pattern, thus not damaging the healthy part of the vessel, but shaving off the diseased calcified plaque part of the vessel. It shaves these particles into very small size that they can not clog the artery as it goes downstream. Smaller than a red blood cell, smaller than the capillaries. Here you see the device spinning, and that's a diamond burr that's once again, eccentrically spinning so it cannot damage the healthy vessel, but can shave the plaque, thus allowing us to get a good opening there where we could then perform our stent, which would be a more permanent form to help facilitate and form structure for this artery to stay open.
Yeah, so Dr. Rochon, you're correct. Now, I don't want the audience to think that this is an expensive device since it's a diamond coated, that sort of thing. But the fact is that they are able to do this to where it sands these vessels down. And there are specific vessels that only this will work on. There are specific ones only lasers will work on. What I want the audience to know that all of these are small. All of these are the size of ink pens or smaller. All of these are in our toolbox. All of these are in our outpatient labs. All of these we can offer to our patients with accuracy in an office diagnosis with these simple tests. We take them in with these new technologies. We're going to be able to create a better blood flow using all these different technologies, and we have them all at our hands, and these are available to our patients. They weren't available 20 years ago. 10 years ago they started. Now they're refined, and there's even more coming. Let's have another call, please.
Hi, good evening, doctors. Thank you for taking my call. Years ago, my grandfather had PAD and it required a long surgery and a 2-week hospitalization to treat. Then, a few years later, he required stents in that same leg, but this required several days again in the hospital. Now, I understand these procedures can be done in an outpatient setting and go home in a few hours. How is this done today?
Well, since I was commenting on that, let me take this one also, okay? So in our field and in our world, almost on a yearly basis, we've got something that gets better, gets smaller, gets easier to use, which makes us able to treat these patients quicker, faster, less contrast, less of everything, less anesthesia, smaller holes, and this allows us to have moved these patients from the hospital into the outpatient setting oftentimes. I've got a video on a couple of different technologies that I would like to talk to you about real quick. What this is showing is a special catheter. Now, these procedures we do are with wires and catheters, and to the audience, these are the size of a pasta angelini. These are very thin. These are wires. These are catheters. And the blood vessels, as you can see, are tortuous. There's blockages. There's all kinds of different anatomies. Years ago, we didn't have this. It might have taken us an hour to do this one little maneuver. Now we have special catheters, smaller. They're going in. They allow us to maneuver more accurate, safer. So we've got different catheters and different things like that we didn't have before. Here you can see this is a torqueable, steerable, almost like a periscope. And again, they're cost effective and they're cheap in an outpatient setting. So this new catheter has allowed us to treat more, treat them safer, quicker, less anesthesia, less of everything, and that is what that device is. This is another device. On occasions, we have blockages that are like a chunk of granite that we cannot cross. In the past, these would have to have surgery or we would have to bypass them. This is a technology in which we have learned to go around a total blockage that we can't get through. Laser won't allow it. We can't get through it. We can't remove it. I used to have to operate on this patient. Now we have this device in which allows us to re-enter. So in other words, we strategically go outside of the lumen where the blockage is, and we put this special catheter into the wall. And we are able to use a special kind of ultrasound that allows us to find the artery on the other side of a total blockage. This allows us to accurately find it and then connect the two arteries. This is an ultrasound device. This re-entry catheter has a little needle. This allows us to identify the normal artery on the other side of a total blockage, and this can be just like a tooth, just like a molar, just sitting in the middle of the artery. Here you can see the device has identified the normal artery on the other side. We're seeing this all after a numbing shot. This is all catheter based. The patient is awake. We identify this. You can see the small needle coming. This now allows us to gain access back to the normal artery on the other side, and we place a wire, and then we treat over this wire. Beforehand, we couldn't get through this. We would have to take them to surgery to remove the blockage or do an open bypass. This is simply a bypass around it within its own blood vessel. This is called a reentry tool. We use this in the outpatient, and these patients used to have surgery. Now they come in, we use them as an outpatient. This shows a stent. We've been talking, this just shows and illustrates how this nitinol stent is actually placed. This is metal, it stays in, we put it in the blockage. It is that easy and that simple to do. The very first stents we used many years ago, they're different. This shows a contemporary nitinol stent that we will use in most peripheral vascular disease. One of the things that we used to have to do is keep the patient on their back for 6 or 8 hours. We would have to do surgery. We're limited because we had large devices. Now we have special things we call a closure device. This is a manta closure device, and this simply allows us to take big catheters, go into the arteries, and do treatments, and they close them back immediately. We are actually even replacing aortic valves, doing almost full heart surgery without incisions today, and that catheter allows that. So this is a whole series of things that I hope the audience, the message here is we got better tools, simpler tools, faster tools, better tools that we can use quicker, easier, safer as an outpatient. Patients love it. Healthcare costs are better. The results are good. This is contemporary medicine in the cardiovascular field that we're able to do. So, guys, let's have another question, please.
Good evening, doctors, and first and foremost, these educational events have been fabulous, and I've learned so much. So my question this evening is, my family was told in the past that angiograms can poison the kidneys and cause kidney failure. Today, is that still true?
Well, thank you for your kind comments to begin with, and that is what we want to do, is provide education to our community, and it is good to hear that. The answer is going to be given by Dr. Pat Lola, because things have changed there too. So you can add this discussion to why we can now do things as outpatients also without injuring kidneys. Dr. Pat Lola, tell us how we do that now.
Absolutely. So until recently, the only way to image or take pictures of the arteries or veins was using iodinated contrast, which is iodine, which is extremely poisonous and toxic to not only abnormal kidneys but also to normal kidneys. And of course, we take several precautions doing it for 25, 30 years. The main focus during the procedure is to minimize the amount of contrast what we give. That's number one rule in this field of treating complex vascular disease. Always number one. But now, lately, over the last few years, we have this new technology wherein in certain conditions, especially doing procedures below the level of your diaphragm, okay? So we could use a special gas, which is called as medical carbon dioxide gas. Instead of using contrast, we inject gas into the arteries or veins, find the problem, find the blockage, try and fix it. And this is also very commonly used in our outpatient labs where patients come to get these complex procedures done. So the patient is safe, we are safe, minimal use of or no use of contrast, and we can use as much medical grade CO2, get all the information needed, and these patients can be effectively treated and discharged home safely with no kind of problem or toxicity to the kidneys. Many studies done, and they have shown that this use of medical CO2 gas is pretty much safe as long as we use it below the level of diaphragm. Anything above the level of diaphragm, meaning heart or your carotids, preferably we tend not to use it because of the risk of complications called as gas lock and all those things. So below the knee, below the diaphragm, any of the arteries or veins can be clearly visualized in a crystal clear fashion, and we can treat them very safely and appropriately.
Dr. Pat Lola and Dr. Rochon, I think you'll both kind of agree. We knew about this 3 or 4 years ago. But it was hard, and industry had not built us the appropriate tools, okay? And just like everything, we had industry come in. They had their reasons. They now made the tools to use CO2 angiography easier, better, safer, and it's a standard thing today. I mean, just 10 years ago, these people would come in, and they would take these procedures would take, let's say a standard peripheral vascular procedure would take an hour and a half, 2 hours. Simple as that, okay? Because it took us that long to do them, and it took that much anesthesia, that much contrast to get them done. No wonder they had to stay in the hospital. Fact is, we can do these things in 10, 15 minutes nowadays, and I'm not belittling the hospital, but I'm telling you we have the ability to do them safer and quicker because of experience and because of technology, and everybody benefits. Let's have another caller, please.
Earlier this year, I saw an article on a new vein stent that you three doctors on the program used in a new procedure for vein stenting. Can you describe this new procedure and what patients will benefit from it?
All right, there's the great question from the vein standpoint. I'm going to ask Dr. Roshan to think about this and address this, okay? Because this is something we've only in the last decade or so started to think about and now have some technology too. I'm going to let Dr. Roshan explain that to you.
Yes,
Dr.
I did
Roshan.
see that. Thank you. And I was happy to be part of many companies and device companies come do research with Dr. Ali and Dr. Padlola in the outpatient setting. And we did have opportunity to deploy a new stent in the venous system. We mentioned that there will be another show talking about the venous system, which is returning blood flow from the lower extremities back to the central cardiac system. This could be done in May-Thurner syndrome and also called iliac compression syndrome, where this is when the left iliac vein can be compressed by the right iliac artery, but it can also happen or have a compression type syndrome in the right iliac vein. Big risk of this causes swelling. It also causes pain. You can have not good blood return back to your heart and cause wounds as well as ulcers. We have technology now that we screen with ultrasound to see if you do have evidence of reflux or problems in this venous system. After that, we would then proceed with an angiogram where we can diagnose and measure the inside of this vein to see if it is indeed compressed. As you can see here, the red is the arteries, the blue are the veins. The arteries can come across and press and compress it, thus giving you a risk of blood clot. And the concern of the blood clot during there would be that this could break off and go to your lungs and cause a pulmonary embolus, which could be quite lethal. We can diagnose these things early. Some have asymptomatic, some are not, symptomatic, as I mentioned, and with ultrasound and then angiogram, intravascular ultrasound, during an angiogram we can perform balloon angioplasty and then stenting.
Sure. Yeah.
Here you can see the iliac vein, the iliac artery compressing the vein, thus causing a problem. We would initially diagnose this with ultrasound, and then this is whenever we would bring the patient to the outpatient cath lab. And in a simple procedure, we can confirm this with the next slide, please. Next, this is once again showing the compression over the veins. And can I have the next slide, please? Here is the angiogram where we're injecting dye. The hazy area there gives us a clue before we even put an ultrasound through it that, hey, there's compression here, thus causing a problem. Next slide. Here you can see we did the angiogram, and on the right here you see a stent deployed, and you can clearly see with the dark area is much more improved blood flow, thus alleviating the problem. And this can also help prevent risk of blood clots there, but also help for better blood flow to heal the pain, swelling, ulcers and wounds, and stasis changes of blood flow not flowing adequately from the lower extremity. Once again, here you see the angiogram on the moving from left to right here. You see the initial, that's the dark dye is not moving up well. Next, the balloon was formed, and then stenting, and you can see that it's much improved flow. This can all be done in an outpatient setting, in an outpatient lab. We do this very proficiently. Patients typically can be home in 2 to 3 hours after that. The actual procedure itself, and this is from initial presentation to going home, the actual procedure itself may take 15 minutes.
All right. Thank you, Dr. Roshan, and here you can see the stent that's in place. What I can tell you is this is a much more common disease. We've not had tools to fix this until recently. And from the standpoint of technology, these are larger blood vessels. They are different than the arteries. It's only in the last few years have we been able to have stents built for this. And again, we were able to do some of the very first of those stent works. And this is a much more common disease than we know. Actually, statistically, younger patients will have it. Females will have it more than males. And so it's something that we're looking for, and patients are getting a lot of relief with this particular procedure. So what we're going to do is guys, that's going to be our last call, as we're really down to about 1 minute. And so what I want to do is I want to thank everybody for joining us tonight. Another epidemic, peripheral vascular disease. We've got our COVID to continue to do the best that we can, wear our mask, do the things that we need to do to prevent that infection, and follow the CDC guidelines as best we can. We've got this coming up in the fall to deal with. A part of our community, we need to stick together. Here you can see our next month's show. And this next month will be on the date, as you can see. We're going to be talking about aortic disease. We're going to be talking about disparities in the aorta, aortic valve, and disparities that have to do with that treatment. We're going to have Dr. Antoine Keller join us also. Dr. Keller is one of our partners in the past. He is now in Baton Rouge. He's taking a leadership in the disparities work. We're going to work with him. I want to thank the audience. I want to thank Dr. Pat Lola. I want to thank Dr. Roshan. And join us next month and go online, get our complimentary book. Thank you very much.